Good day, my dear undergraduate students. The series of classes for the day are spotters for the exam. Already we have covered a lot, and in the first class I shall be covering these. Kindly read them. They are important as not only slides for identification, but as questions for Viva and charts that might be given for the practicals. Also, during our differential count and other exercises, we shall be having the first one shall be Eosinophilia. Again, the importance is where here I would like you people to kindly go through this box. The mistake that the students do is writing just 2 points, and we are not able to score the maximum marks which we very easily deserve. The first slide is regarding the identification of the cells, which you people already know from your physiology onwards. Here, there are two groups of cells. One is called a granulocyte and the other non-granular leukocyte. The neutrophil, the eosinophil, and the basophil have all got granules. Neutro, because it has got a neutral color, neither blue nor pink. Eosinophil, it is eosinophilic or pink or brick red, and basophil, blue in color. So these granules are small, the nuclei are not obscure. The granules in the case of the eosinophil are larger, brick red, and we have got the bilobe nucleus for identification. The basophil, on the contrary, it has got coarse, large, blue granules which obscure the nuclear details. The other two friends of ours, lymphocyte, though we say smallest, slightly larger than the RBC, the nucleus is about the size of the RBC, scanty cytoplasm. Monocyte, kidney-shaped nucleus, abundant cytoplasm, largest of these cells. This kind of a field will either be focused for you people or will be given in the chart that is distributed to the students. Therefore, it should be easy for you to identify. We need not move the field and strain. Straight away it is over here. I am able to see the brick red granules. The point that you people will have to write for the diagnosis will be brick red granules. The nucleus here is bilobed or spectacle shaped. But look at this cell. It has got 3 lobes and the granules are brick red. Therefore, I must not call it a neutrophil. It is an eosinophil. It can be trilobed, particularly in children. The usual count is about 2 to 6%. And one question that I usually ask the student is, what is the absolute eosinophil count? And they say 2 to 6%. Absolute means the number, total number, which will be 40 to 440 per cubic millimeter. So that is the importance of the eosinophil. So these slides are given to you for comparison. There should be no difficulty at all. Go by the color of the granules in the cytoplasm, your diagnosis is correct. And the irregular nucleus is found in the neutrophil and the eosinophil alone. Even in a slide like this, you people can very easily make the differences, the lymphocyte and the eosinophil. Now, what are the causes for it? A common question. It can be in allergic reactions, such as bronchial asthma, hay fever, eczema, contact dermatitis, parasitic infestation. And in some cases, I find that the absolute count is 1500 to 2000 cells per cubic millimeter. So it is markedly increased. We call it as hypereosinophilic syndrome or the low-flux pneumonia which is classical of a wandering parasite. It can be familial also, idiopathic, and it can occur as an important component in the chronic myeloid leukemia. Even otherwise, the eosinophils are seen, but there is one variant called the chronic eosinophilic leukemia, where eosinophils will be markedly increased. In the tissue, we can be finding angiolymphoid hyperplasia with eosinophilia, Hodgkin's lymphoma, etc., or eosinophilic leukocytosis, histiocytosis X. These are all some conditions which you people should remember, at least a few, so that you are able to answer in the exam. And for the spotters, do not write the causes and all. You must write the points in favor of the diagnosis. The questions that can be usually asked shall be the causes, the identity, the count, any syndrome that is associated with it. In neoplasia, what are the tumors that are associated with eosinophilia, IgA nephropathy, bronchial asthma, and type 1 hypersensitivity, we shall be remembering. And for all this, I would advise you people to kindly go back to this list and complete it before your practicals and viva. The next diagnosis that we are going to see is neutrophilia. Simple slides will be given to you people. The neutrophil is identified by means of the fine granules which are almost colorless. Eosinophil large brick red and basophil coarse blue overlapping the nucleus. The precursors for these shall be the myeloblast, promyelocyte, myelocyte, metamyelocyte, staph forms, and the mature neutrophil. This we should know for the benefit of leukemia, leukemoid reaction, as well as the vibe. So this is the neutrophil. I am seeing a beautifully drawn picture. It's a three-dimensional one. Neutrophil, the lobes of which are being interconnected. I am seeing a three-lobe form. It can be having 2 to 5 lobes usually. And look at the granules over here. They are almost colorless, blending with the cytoplasm. Hence the name neutrophil. They are found in conditions such as acute inflammation, because this is the first line of defense. Whenever there is an inflammation or an infection, these cells will come first. They have a very short lifespan, 1 to 2 days, and after which you find that the next level of cells will be taking over. So acute inflammation, such as acute appendicitis, myocardial infarction, any bacterial infection with abscess formation or septicemia. Incidentally, chronic myeloid leukemia. Chronic myeloid leukemia, you can have it as a last choice because almost all the cells will be increased. Neutrophil, eosinophil, basophil, etc. But that should not be your first answer. As I had mentioned, it has got 2 to 5 lobes or segments. Colorless granules, 10 to 12 microns, smaller than the eosinophil, but much larger than the RBC. Sometimes we can have dark granules or vacuoles within the cytoplasm. These are called as toxic changes. Whenever there is an infection and the cell is aggressive, you will be able to see this. There is a counterpart of this called the leukemoid reaction. Leukemoid means it resembles a leukemia, and hence the term leukemoid reaction. Look at this particular slide. There is a marked increase in the neutrophils. I am able to see the segments. But then, this is a C-shaped cell, not a monocyte, but a precursor of the neutrophil, the staph form. And I am seeing another one over here. Sometimes there can be cells such as myelocytes or even promyelocytes. Very rarely we see a blast. So, the cell count is increased. It can be up to 1 lakh. In neutrophilia, the count can increase up to about, say, even 50,000. There is a shift to left in a leukemoid reaction because I am finding immature cells that I had mentioned earlier. Toxic granulation can be seen. The precursors such as metamyelocytes, myelocytes are increased. Blast very rarely seen, less than 1%. So it will not be confused with an acute leukemia. The lab score, leukocyte alkaline phosphatase is increased. Go through your chart, this will be a clue. And also there can be the manifestations of an infection, such as a severe pain, or sometimes you are finding a change in the ECG, etc., for a myocardial infarction. Culture and sensitivity in an abscess or a meningitis can be positive. And radiology also will be giving the features in a leukemoid reaction. If you go back to my book, there will be a tabular column which you people will have to read. Leukemoid reaction is a university essay question asked at least 200 times. And this is an important chart for the university exam. This chart also can be kept for us. So it is a case of an acute inflammation. Look at the sheets of neutrophils that I am seeing. There are lots of these neutrophils, and there is a higher magnification of the same cell. Sometimes the granules become a little coarse because of the toxic change. Now the history can be a patient presents with neck rigidity, headache, projectile vomiting, and high fever. These are the classical features of a meningitis. And normally no neutrophil will be seen in the cerebrospinal fluid. Even if you see a single one, it is an indication of an acute meningitis. And if I see so many neutrophils, straightforward, the diagnosis is acute bacterial meningitis. Now, what are the questions that can be asked? Look at the neutrophils over here. This probably can be a eosinophil. You can appreciate the difference. What is the lab score? What is the leukemoid reaction? What is agranulocytosis? This is also a university question. I had given it in my text. Go back and read. Aplastic anemia, it has been asked 200 times. No cells will be seen. Shift to left. That means immature cells will be present. Hypersegmented nuclei can be seen in a case of a megaloblastic anemia. And phagocytosis, what is the importance of the defects in phagocytosis? Is again a university question. Kindly go back to it. You should be prepared for the questions in the Viva, MCQs, charts, slides, and questions during practicals. Many a student, they fail in this. They just do some differential count and present. But when the examiner asks, we are not able to answer. This will be actually fetching us more marks. Thank you for your patient listening.